Good evening, everybody. I'd like to thank you, Manos and Manos, once again for inviting me. This is a great honor for me being here. So I was asked to talk about arthroscopic transosseous repair. So I'd like to start with a very quick overview on rotator cuff repair history. So let's say that everything started in 1944 with open transosseous repair, and then we slowly switched to mini-open, first transosseous, then suture anchors, and then we switched to an all-arthroscopic approach with suture anchors. We developed multiple configurations, single row, double row, transosseous equivalent, and we compare all this configuration. And now I think it's quite funny, because if the first biomechanical studies just try to assess, just try to demonstrate that suture anchor repair were comparable to open transosseous or traditional transosseous, quote unquote. Now, most recent biomechanical studies just try to say that arthroscopic transosseous are comparable to single row, double row, or transosseous equivalent, so to all arthroscopic technique with suture anchors. And I think it's a funny story that we are going back to the beginning. So, regardless the technique and the approach we will use, we aim to get a perfect repaired cuff. And what does it mean, a perfect repair cuff? It means that we want a stable construct from a biomechanical standpoint. We want a very good function. That means unhappy patients. That means a patient with a full recovery of the range of motion, a patient with all strength recovery, and that is able to return to work and sport activity. And even if we are in the 2020, we still are hoping for a biological healing. That will be a perfect cuff. But let's start with biomechanics. What are the biomechanical characteristics we are looking for? We are looking for a large contact area, high contact pressure, high initial fixation strength, and stable contract, and of course, a low tension repair. And what do we learn from biomechanical studies up to now? According with the previous speaker, we can say that we are all agreed that double row repair, and specifically the transosseous equivalent, for sure are the best construct from a biomechanical standpoint, because they have higher failure loads, lower gap formation, and the suture bridge, so the transosseous equivalents, also have an high contact pressure even compared to standard double row constructs. So we can say that our comparison tonight will be for transosseous equivalent and arthroscopic transosseous. And when we talk arthroscopic transosseous, we're just saying that we are looking for a way to perform some bone tunnel. But once we got the suture in the tunnel, we can apply for multiple configuration, starting from simple suture to Mason Allen to H-shaped configuration that has been described by the group of Professor Castagna that is here, and the more complex configuration like the X-box. Why I'm telling you this? Because when we look biomechanical studies, we need to focus on what kind of configuration we are comparing. Otherwise, we're going to get the idea that biomechanical studies just show controversial result, and I think it's not. Because we say that if we compare transosseous equivalent and transosseous repair by using simple repair, surely transosseous equivalent look better. They show higher mean failure loads compared to simple repair. But if we compare two similar constructs, such as transosseous equivalent and the X-box configuration, results are almost the same. So they are both strong and stable. And according to what I'm saying, a recent meta-regression analysis, systematic review and meta-regression analysis of 40 cadaveric studies just say that what makes the difference are not the anchor or not the bone tunnel, but the number of suture and the suture limbs that just pass through the cuff. So it looks like the more, the better. But talking about suture, so suture configuration probably makes a difference from a biomechanical standpoint. Let's see some surgical steps, actually. To perform a transosseous repair, we can use different devices. This one is the Taylor suture, which is basically a carved needle that go from the lateral aspect to of the greater tuberosity to the footprint, and then we use just a passing suture to pass all our suture. Usually I pass 3 suture. And as I was saying, we can just make any configuration we want, from single repair to more complex configuration. Another surgical device that we can easily use is the arthrotunneler device. It's similar, it just works in the opposite way. So the first tunnel I drill is a vertical tunnel, just where I usually put my suture anchors. And then this is just a dilator. And then I put the device just in the first tunnel, and the device is perfectly fit with the greater tuberosity. I drill my horizontal tunnel, and then I retrieve my, my passing suture. I can perform as many tunnels as I need. So in this case, I will perform a couple of tunnels. As you can see in a second, yes, that's the second tunnel. And then sometimes before not tying, I just perform some microfracture or nanofracture. In this case, I will perform an X-box configuration. So I will pass through the cuff my, my passing suture actually. And through the passing suture, I will pass all my suture through the cuff and through the bone tunnel in one step. Or two step in this case, because I got two tunnels. And after that, I'll just need to tie the suture according to the X-box configuration, which is that. So from a functional standpoint, from a clinical standpoint, I can show you actually only two studies, which are the only two randomized clinical trials available on this topic, because all the other studies are just case series. They say, okay, transosseous equivalent just reached very good clinical results. But let's see a comparison in a randomized clinical trial. This has been conducted by an Italian group. They compare 35 single row repair versus 31 transosseous repair. Unfortunately, sample size is not very high. And from a clinical standpoint, at the final evaluation, at an average follow-up of 40 months, they say no difference. What they found only a significant difference in pain management. They say that in the first 3 weeks, or at least 3 weeks after surgery, pain was inferior, people who underwent a transosseous repair just get a lot of less pain. And from healing standpoint, no difference actually to the MRI. Next study is quite different. They compare only 10 transosseous equivalent repair versus 11 transosseous. I know the sample size is even lower in this case. They look for difference in vascular pattern. What does it mean? That each patient underwent an ultrasound evaluation and 1 month, 2 months, 3 and 6 months postoperatively. And they found that at least for the first 3 months after surgery, the blood flow was more evident in the transosseous repair, probably because it came up from the bone tunnel as well. So they say that there is a potential biological healing increased by the transosseous repair. Let's sum up what advantages we can get with transosseous repair. Actually, if we are repairing small tears, so we need a single tunnel, and if you use one of the devices that I show you, probably it's cheaper if you perform a single row repair. But if you need to repair a medium to large tear, so maybe 2 or more tunnel, which means also at least a couple of anchors if you do a single row, or 4 anchors if you do a double row repair, surely transosseous repair can be considered cheaper, so they are cost effective. What about the techniques? As you see, even in my hands, it is not so difficult to perform the bone tunnel. So especially if you do simple suture, the technique is very easy. If you choose a different configuration, it could be a little bit more demanding, but I mean, not so big. For a biological standpoint, we can say that from the tunnel, we can get bone marrow from the tunnel. We can also add microfracture, and this is another advantage. But what makes the difference probably is the revision. If you have to revise a case with transosseous, it's surely easy because you don't have any implant. Are there there any concern when you look at transosseous repair? Sure, we have a couple of concerns. One could be bone quality, so osteoporotic bone, and tunnel angle. Let's see. Bone quality could be easily solved just by adding an implant, I have to say. Different type have been described, so button, small fish, the elite, even knotless anchor, any kind of augmentation through the lateral tunnel. And for the tunnel angle, what we can say, two problems. One is the bone bridge, but if you use one of the devices that I show you, you don't have to care about the bone bridge. I cited a study that always, of course, talk about open transosseous, and they say that the bone bridge is sufficient when tunnels are placed at least 10 millimeter distal to the tip of the greater tuberosity, but as I said, it's not an issue if you use a precise device. If you use an handmade device, like an ACL guide, for example, so you need to pay attention to tunnel angle. And so even the axillary nerve is a potential, there is a potential risk. I say potential because no reports are present in the literature, but there is a study that showed that in order to be safe, to stay at least 5 millimeters away from the axillary nerve, you need to drill your angle at least 60 degree with the horizontal axis. So in conclusion, can we avoid implant? Yes, we can avoid implants, basically. From a biomechanical standpoint, we show that they're totally comparable to the transosseous equivalent. From a functional standpoint, results are comparable to current technique, even if of course, we need larger sample size. From a biological standpoint, bone marrow from the tunnel looks like something we need to pay attention, and nevertheless, easy revision is something we need to think about. Thank you, and I hope to see you in Milan for the ESCA meeting. Please, 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 don't forget to like our Facebook page, the ESCA ESA. Thank you.